Good morning, dear ladies and gentlemen. Welcome to Contemporary Digital Implant Dentistry with C-Guide. The topic today would be the parameter of aesthetics on implants and their application in the digital workflow. In the freehand surgery, we had, based on science and clinics, defined parameters of implant design, implant position, grafting procedures, dimensions of the bone and of the soft tissue around implants. Now, in the digital workflow, we have technologies where we have to implement those parameters and also to find techniques and methods to make the treatments more minimally invasive, since this is the sense of the digital workflow. So the question is, and what I would like to discuss with you today is, where are we in this digital dentistry field? Which are the parameters which we know? How do we apply these parameters in the digital workflow? And which are maybe the parameters which we are still looking for and we still want to implement? And also, which are the technologies which are still missing? Which are the parameters which are still to be found in order to do the treatment even more minimally invasive, aesthetic, and functional. So in the freehand implant placement, we managed to reestablish bony situation, soft tissue situation, and transform them in kind of pleasing aesthetic situations in adjacent implant reconstructions. All these parameters of aesthetics were defined in different studies, own ones, but also generally. And we realized that we have a high success of the osseointegration in all these cases, freehand placed cases under certain parameters. Now, today we work with static navigation and dynamic navigation, and actually each and every case is an digital planned case and a digital or a navigated surgery, because we realize that those treatments can be even more minimally invasive. They have a higher precision than the freehand, also an immediate placement of implants. They have a better aesthetic and functional outcome, a higher predictability, also because the planning is much more clear and much more controlled. And it's a reduced time of the surgery if it's made well. Planning is the longer time. The surgery, which requires the presence of the patient, is much more reduced, much more controlled, much more predictable. Nevertheless, we need to find some additional parameters in order to apply and to add all these technologies and to make them match together in a coherent workflow. Now, the digital workflow is applied in our offices since a couple of years, and if we do a one-year follow-up on 12 patients, we see even a higher success of prosthetic reconstructions after 1 year, but more studies are needed. Some of the cases that we address today are part of the study and are the base of our parameters, aesthetic parameters, which we would like to design and to define for the future. The static navigation has 4 steps: scan, plan, make, done. The scan stage is the acquiring of all the digital informations of the patient with all the technologies which we have today. beginning with a photography, video of the patient, face scanning, an intraoral scan, lab scan, an occlusal analysis of the patient, a registration of the movements of the jaw, and a DICOM data acquiring with a cone beam CT technology. The photography is useful because not only for documentation, but it's a sine qua non condition for the technician to build up and to visualize 2D and 3D the future smile. We use cone beam CT technologies which have certain features, low dose capabilities, and we will work in the future with definitely 3D technology and not with a 2D. The jump is very short to that. A secure patient positioning, since we know that the positioning of the patient is one of the sources of mismatching, discrepancies, and distortions between the planning and the result. Then artifact reduction algorithm, a high image accuracy, and so on. We use intraoral scanners which have as high accuracy, precision, and trueness as possible, and that is why we follow the studies made and done by societies and by researchers, taking into consideration more and more newer intraoral scanners. We have the conclusion, preliminary conclusion, that we have a high accuracy of the intraoral scanners in single tooth or in reduced number of teeth situation or implant situation, but in a full arch situation, the accuracy is not as high as expected or as wanted. Another data acquirement is the registration of the movement of the jaw digitally, which is a huge benefit, a huge advantage, because it avoids the bite registration and also the face bow. Another advantage is that the movement of the jaw can be transposed in an increased occlusal vertical dimensions, which will be done in the same device, in the same technology, and this situation will be transported in all the phases of the digital workflow to the provisional restoration, immediate loaded provisional restoration, but also in the final restoration. So that movement can be implemented, the digital movement will be implemented in the planning software and in the CAD/CAM software, and worked with this movement and with this bite situation registered at the beginning. Sensor-based occlusal registration and adjustment is a mandatory condition when we work with implants, and this is the new state of the art of the occlusion. Blue paper is last year. We need a much more sophisticated and much more precise technology which offers us a precision of 25 microns in order to avoid overloading, shear forces, interferences on implants, because as we know, implants has no resilience, and all the prosthetic parts has not the resilience of the constructions on natural teeth. So we need definitely, and since we know the complications which can occur as a result of the overloading in terms of bone loss as one of the causes of peri-implantitis, we realize how important is a very good adjustment of the occlusion. Then the next step is plan. What do we plan? We plan digitally. What can we plan with the technologies? 2D and 3D planning of the smile. So after the 2D planning, we match all this information that we have in the 3D planning. So beginning with the photography, where we can visualize with different softwares and technologies the new proportions of the teeth matching to the face. Now this 2D technologies made by Keynote can be automatized with some softwares, or even with the help of artificial intelligence and virtual reality or augmented reality, to visualize in movement the teeth of the patient, adjust dynamically the modifications in movement. So very fascinating technologies to visualize 2D the teeth. Now, this 2D visualization can be, of course, walks-up to virtual walks-up, can be 3D done in the CAD/CAM software, matched with a face scan or with the photographies and with all the other virtual data which we acquired. This matching all this data, and the matching is also based on, sometimes on some of the parts of the matching are based on artificial intelligence, is the base for planning the guide, the surgical guide, planning the implant position, the graft amount, the amount of, and the technique of the bone grafting or soft tissue grafting, of the implants, surgical guide, and of the provisional. Artificial intelligence is helping us also to find the nerve on automatized base. Also, the position of the implants will be done with help of the artificial intelligence on the spot. And this is all studies, ongoing studies. Now, after the planning, the planning is the base to the manufacturing of the parts. And the technology used for manufacturing is the printing and milling technology. Now, printing is the future milling. Printing is depending, the quality, accuracy of the printing is depending on the quality of the printer. And we print surgical guides, provisionals, models. Now, of course, there is need to studies regarding the accuracy of the printers, of the 3D printers in dentistry. One of the recent articles published together with Francesco Mangano, Matteo Bonaccina, Davide Faronato, and other colleagues are showing that using an initial reference, and also orthodontic models printed, are showing that there are linear discrepancies between the printers, amplitude discrepancies, and also diameter discrepancies between the printers. And this is very explainable because the technology behind the printer is different. Some are stereolithographic technology, the others are light based on mirroring the images, and also the material used by the printers is different. Another interesting conclusion is that the linear and diameter measurements are different between the machines, and the trueness of the models is after 1 year after printing is different. That means that there are some dimensional contractions which happens over time. So this is a very interesting conclusion. Now, after we printed all these parts, we go to the surgery where we have all this part pre-prepared, the plan already done, and with the help of the static guide, we will place the implant in a perfect aesthetic driven position. And of course, all these workflows has a certain accuracy or lack of accuracy, which is subject of many studies, actual studies, ongoing studies, and previous studies. Beginning with simple cases and ending with more complex ones, let's go to different workflows discussing about different issues in all these 4 steps and different parameters used and to be used in the planning. Now, this is a case of a 12-year-old lady which is having had an accident and has a soft tissue deficiency, which will be corrected by a connective tissue graft in the first row. And then having the enough amount of bone, we do a digital planning of the implant. This is the perfect positioning and the soft tissue situation after the provisional abutment. Respecting the amount of the soft tissue gained and respecting the design, the S-shaped form design of the final abutment, we can get a nice aspect of the soft tissue around the single implant, but also adjacent implants. We know that the S-shaped concavity of the transmucosal portion of the final abutment will conserve a firmer connective tissue barrier. That is why we use implant systems which which have already the concave profile of the running room and is the base, which is the base for a very nicely done individual abutment. That is why the final result in the model, but also the final result in the mouth, are very pleasing. And this situation is stable in time. Another case, more an interdisciplinary case, is a missing lateral case of a young lady with a kind of gummy smile. The orthodontist opened the side for an implant in the lateral zone, and after finalizing the orthodontic treatment, we make a smile design with a keynote procedure to see what is the aspect, what would be the aspect of the final reconstructions which the patient can have in order to compensate a little bit the gummy smile and give the patient a pleasing result. So after the 2D planning of the smile, we realize also that we need to do a bone grafting in the lateral area because missing laterals needs to have, it's lacking bone in the missing lateral region. And we choose an incision techniques which don't give, not an intrasulcular incision, which gives a recession, but also not an papilla sparing incision in order not to have scars in that visible gingiva. So we use an incision which is an hybrid incision between the both with the papilla sparing and half intrasulcular incision. So the aspect of the tissue after the grafting is like this, and then we can go to the 3D visualization of the, or 3D walks-up based on the 2D visualization of the smile, and the planning of the implant based on the aesthetic 3D walks-up, digital walks-up. You can see in the planning software the amount of bone grafted and the reality that we can place now the two implants in an aesthetic position. We respect two important planning parameters I will show you in a minute. And after the planning, we can go with a very precise guided surgery. The parameter of planning respects two algorithms. The depth of the insertion, which is around 4 millimeters from the free gingival margin that we achieved, right? And the implant is also 1 millimeter subcrestally at least. And another parameter is the total buccal distance. That means the distance of the color of the implant from the most buccal contour, which you see with a green line, should be totally around 4 millimeters. By this preliminary planning, we realize that after the uncovery and after the doing the CAD/CAM milling, planning and milling of the veneers, after 2 years we have we superpose the STL file with the cone beam CT of the implant planning, and we realize that the distance which we planned is still there. That means this parameter is enough to maintain the stability of bone and the soft tissue or the main volume around implant. That means the aesthetic appearance of the construction in the long time. And based on the future cases, we respected this parameter on the following cases. We respected these parameters as an algorithm, not necessarily the amount of the bone and the amount of the soft tissue separately, but the sum of these two dimensions buccally and vertically, meaning in the depth of the insertion, and evaluated the results. So this is the case of this young lady. So what is the situation in the full arch navigation? we have the same workflow in the full arch navigation by scan, plan, make, done. Immediate placement, immediate loading. Trying to define the algorithms and to respecting the algorithms which we preliminarily know in all these cases and evaluating the result. This is an ongoing study. The FP1 situation is the situation where you place the implant in an extraction socket without destroying the structures existing there. Soft tissue and bony situations are enough, are sufficient for our restoration. And this is an example of the workflow in a daily base. We scan the situation, we do photographies, the patient has a disastrous situation, we match and plan the future smile in an exocad planning software where the implant is also implemented. We implement the movement of the jaw which we registered of the patient, and this movement with an increased occlusal vertical dimensions is the base for the provisional which we do in advance, and also for the final. This is the same environment in the digital environment, including the movement which we use for the final. We plan the implants in a tooth by tooth reconstructions, upper and lower, matching also we can match also the face scan in this environment, and making all the steps in this matched procedures, technologies. Then we plan the implant and the guide in a way that is a tooth-supported guide. We know from studies that the tooth-supported guide is much more stable than the soft tissue-supported guide. That is why we choose always a strategy where we maintain 1-2 teeth, which afterwards will be extracted in order to stabilize the guide by some existing teeth, right, in our upper and lower. The make stage will consider the printing of the guides with this time a sleeve guided surgery, and also the manufacturing of the provisionals based on the 3D walks-up. We use different methods to match the provisional in the perfect aesthetic position, like that palatal base. And then we go to the surgery, which is actually the perfect translation of the planning into the mouth in a very structured approach. That needs a previous session with a team and with a technician in order to see the priorities of every member of the team, and if that is made in advance, the surgery itself is happening in a minimum of time and a minimum of efficiency and the less of mistakes, upper and lower. We also use the socket grafting, and in the sockets which the implants are placed, the previous mentioned parameters are respected in the depth of the insertion, but also in the buccal dimension, buccal palatal dimension. We use always multi-units abutment to screw retain the provisional. We seal the sockets, and the patient gets this provisional to go home. The patient will use in the time of the osseointegration soft food is an immediate loading. The implants which are placed in the sinus elevated regions will not be loaded. Only the implants which are primary stable are loaded. That's why we use implant systems which have a good initial stability in almost all bone qualities. In the sinus elevation regions, we don't have the 3/4 of the implant covered by natural bone. That is why the criteria of immediate loading is not fulfilled. Susan has short teeth, has a decreased occlusal vertical dimension, which we need to increase. That is the base for our walks-up this time. This is an older case. This was made handmade and lab scan wise scanned. matched with a cone beam CT. And this is the base for the planning of the implants, respecting our parameters, planning of the guide in a digital manner, and manufacturing the model by printing, and manufacturing the guide by, in this time, the provisional will have a metal frame because the teeth are not too high in order to avoid fractures. So then the surgery is actually very easily done. Also an internal sinus elevation. We graft also simultaneously, and this is the situation of the patient after the surgery, and this is the situation of the provisional. Now, of course, patient comes sometimes edentulous. And in this case, the planning starts with a cone beam CT. So the patient has only 2 roots, so that makes a difference, because we know already that the guide will be soft tissue supported. So we will have to work with pins. And also the planning needs to be done in a way that the denture will be, or the wax-up will be, of the denture will be matched with a cone beam CT with some opaque references. Ahead of the time, we will do a smile design, and we realize that the teeth should be bigger than before. So this is the wax-up in the form of a denture with opaque points, which will be the radiologic guide in the same time, in order to have matching points with a cone beam CT. Of course, we do a scan of the edentulous situation too, and matching all the components are the base. This is the base for planning the guide, planning the provisional, and to manufacture all the parts which we need then for the surgery. We can get also a model-based provisional and a provisional screw-retained abutments, the provisional in advance, the guide, and a kind of aesthetic guide or simple guide for the lower jaw, since in the lower jaw we don't intend to do a fully guided surgery. The provisional is there, and we go for the surgery. The set of the insertion is very well organized, where we go from length to length and from the diameter to diameter in a very coordinated way, so it's no way for mistakes. The surgical procedure was done, and the screw retained abutments are inserted. The patient is going home with a provisional which is screw retained, and this is the situation directly after the surgery and sinus elevation. The situation immediately after the surgery is quite okay and looks really minimally invasive. Now, after the healing of the implants, after the integration of the implants, which can be between 4 and 6 months, in this case 6 months because of the sinus elevation, we do an impression over the multi-unit abutments. The implant has a conical, more tapered conical connection. Therefore, in order to have no vertical discrepancy of the impression, we do all impressions over the multi-unit abutments with an open tray. In the lower jaw, we can do a closed tray because we do single teeth screw retained restorations. In the upper jaw will be a full mouth screw retained restoration. In the lower jaw, single teeth screw retained. The constructions will be done in a zirconia frame with a ceramic coating on it, and this is the aspect of the restoration and the happy patient. So it's a high jump in the quality of life. Now, this young lady is a particular FP1 situation where really we have all the anatomic structures necessary to do a non-invasive procedure. Nevertheless, we use criteria of insertion of the implant and extraction of the tooth, which are a consensus. That means if a periodontally ill, sick tooth is, after 1 year of treatment, still infected and still mobile, and the residual bone height is less than 8 millimeters in some region, is the time to place an implant. After those criteria, and the criteria that the tooth should be as healthy as to be held in the mouth then for the next 10 to 20 years, we extract all the teeth in the upper jaw, and in the lower jaw we maintain 7 teeth which are stable periodontally on the long run. I have a high predictability periodontally seen. We do a wax-up which we scan by the lab scan. This work was done by Uli Hauschild. We explain the patient what she will get. She will get single teeth in the frontal area, small bridges in the lateral area, all implant supported, and in the lower jaw we will maintain 7 teeth and the rest will be replaced by implants. Matching, as in the previous situations, the cone beam CT data, the DICOM data, with the STL file of the wax-up. This is the base for planning the implant, finding in a perfect aesthetic position, planning the provisional abutments, screw retained or even cemented, planning the grafting in the lateral area, planning all the surgery step by step mentally. So this is the moment where we use all the algorithms which we know regarding the implant design, choose the position, the number, the grafting procedure and their sequence, the navigation type, the surgical guide type even, the prosthetic reconstructions, provisional and final. Some of the steps, meaning implant planning, in the implant planning softwares, in the CAD/CAM softwares, and also in the matching of the technologies are based on artificial intelligence, and this is a technology in digital dentistry which is very, very much incoming. Now, remember the parameters of the bone and of the soft tissue which we need to respect, the 2 millimeter of bone and the 3 millimeter of soft tissue and the thickness, height, and keratinized tissue. We tend to have these parameters. And we tend also to achieve or to maintain a height of the papilla or height of the soft tissue, the cemented restoration as a final restoration, knowing that in very many anatomical situations, like 80%, the screw is coming out buccally if you don't use a multi-unit abutment for single tooth, which is transforming that in a screw retain reconstruction, or a tilted canal. We respect the parameters and algorithms of the depth of the insertion of 4 millimeters, and also the buccal, the distance between the color of the implant and the most buccal contour of 4 millimeters, in order to assure a stable aesthetic situation on time, preliminary. So we have this provisional in advance. We go for a flapless surgery where we maintain 2 teeth in order to support the guide, because we know that the tooth supported guide is much more stable than the soft tissue supported. And we go to the surgery. Which is very well planned, and we can see a precise positioning of the implants, which is much more precise than the freehand, and this is documented in the literature. Due to the lack of accuracy of different technologies, lack of accuracy of the matchings, until now we still have a discrepancy, and also in the discrepancy and the lack of accuracy of the printers. We have a discrepancy between the planning of the implant and the insertion of 0.7, 0.8, or even less, depending on the chain and on the digital workflow and other technologies in the workflow, implemented in the workflow. And this is the subject of a lot of studies, and because we try to decrease the lack of accuracy and to create a smooth workflow with the less lack of accuracy possible. Nevertheless, knowing that there is a discrepancy between or a mismatch between the planning and the placement of the implant, we have to take that into consideration in the planning of the implant. So nevertheless, the aesthetic planning of the implant is as we planned, as you see, is mainly the same as we planned in the software. This is the situation after the placement of the implant and insertion of the provisional, which looks pleasing after the day after, and the patient is satisfied. We check the occlusion with a sensor-based technology in order to have a balanced occlusion and a very well an occlusion in harmony, because it has an immediate loading and we don't have to have overloading on the implants. Now, since we are not doing an intraoral scan over all the full arch reconstructions, we get back to the open trade impression over the multi-unit abutments and the superimposition between the provisional and the scan of the provisional, STL of the provisional, and the STL of the impression, that is the base to build up and to design the individual abutments. Some of the softwares are able to define the margin of the abutment paragingivally or slightly subgingivally based on the soft tissue thickness and calculate the tissue displacement which happens. And those are parameters, those are technologies which we have to implement and to use in the softwares in order to have a predictable margin of the abutments and design of the emergence profile. An example, like a parenthesis now, an example of application of the artificial intelligence in the fixed implant prosthodontics was documented in a recent article published in the BMC Oral Health with our colleagues Francesco Mangano and Jafar and Oleg Atmakin, which is based on the reality of a single tooth replacement on implants, where an individual abutment and a temporary crown was made in a CAD software and was scanned. Now the scanned hybrid abutment will be stored as an STL file in a certain part of the software. Then after the healing, and in order to do the final crown, instead of doing pouring a model or printing a model and doing the final crown, we scan again the final abutment, and the software is able in this moment to take the data, the STL file from that individual case and match it with the actual case through an artificial intelligence mechanism. On the other hand, is able to trace, to place it in the highlighted region and to trace the margin line as it was before, independent of the level of the gingiva after the healing. This way, the software can place and can model the final crown with after this design in the same software, reducing the time of the manufacturing of and avoiding printing, which would avoid at the same time lacks in the accuracy of the result. So the deviation, a mean deviation, was 45 microns, which is really acceptable between the planning and between the quality of the fabrication of the individual hybrid abutment. So that is why is a statement that artificial intelligence implemented is reducing the time and facilitating the precision of the final reconstructions. Back to our patient, the design of the individual abutment have the S shape, which we need to have, and the margins of the abutments are paragingivally or slightly subgingivally. A parameters which has to be respected and maybe implemented also in the CAD/CAM systems is the 3 to 4 millimeters between the margins of the abutment in order to assure the papilla between the implant crowns. Nevertheless, we learn from our mistakes. The situation is after 2 years stable, that the way it was before. And if we look at the initial situation and the pleasing smile of the patient after 2 years, so we definitely have a jump in the life quality of the patient. On the other hand, we observe the stable, bony, and soft tissue situation around these implant designs with a more tapered conical connection, concave profile of the running room, and all the features that we need to have in order to avoid bone loss and soft tissue. So we check that that parameter, and we see that the 4 millimeters are a parameter to be maintained and to be respected in order to maintain the volume peri-implantary in the long run. Now, of course, we reconstruct the structures, but the key on a long-term success, which the patient wants to have, is also the maintenance. And this is made by a recall every 4 months in order to avoid the transition between an eventual mucositis to a peri-implantitis, which is irreversible or very unpredictably treated. So that is why we do a recall every 4 months to treat any mucositis if it's necessary to avoid peri-implantitis. On the top of it, once a year, we do a decontamination with one of the technologies out there and an sensor-based occlusal control or adjustment, especially in not only in implants, pure implant supported situations, but also tooth and implant supported situations, in order to avoid any occlusal shear forces or forces which would damage the implant and cause bone loss. That is why, based on seconds and on microns, the sensor-based technology is able to adjust the occlusion in an implant and teeth situation by implant time delay, or in pure implant situation by measurement by seconds. So all these parameters can be read in the Handbook of Research and Clinical Application of Computerized Occlusal Analysis in Dental Medicine. All the occlusal adjustment has to be done, as mentioned at the beginning, in all the steps of the restoration, from the beginning, provisional, final, and once a year, in order to have one of the conditions fulfilled of long-term maintenance of the restorations. And this is one of the subject of a multi-center study which will be published end of this year. Now, the sleeve-guided implant surgery has its disadvantages by the lack of sterilization, by the sleeve guided surgery, we are not able to control the primary stability of the implant and so on. That is why there are other guides, sleeveless guides, which are an innovation in the field of guided surgery and seems to have a couple of advantages. The technology is guiding not by sleeves, but by the handpiece, which is guided through canals in the drilling, but also in the implant inserting procedure. It seems to be that, by studies, that the precision is even higher than the sleeve-guided surgery, but more studies are necessary to prove that, which are ongoing studies. This technology has, as I said, a couple of advantages more. That means is an irrigation there, which reduces the heat. Then is heat sterilization possible by the guide. It's a good vision, so we can do an open surgery without removing the guide. Then it's no contamination of the implant sites because there are no sleeves. And we have a real implant torque control, that we can control the primary stability of the implant. So there are a couple of advantages there. So this, we did a couple of cases with the same implant design and different guide technologies. The planning is respecting the parameters which we mentioned before. And again, if the soft tissue situation is appropriate, we don't need additional grafting technologies, but if so, then we need to open the flap and graft accordingly with one of the techniques and matrices which we mentioned in another lecture. We can increase the soft tissue thickness by using matrices plus minus PRF in order to predictably increase the soft tissue thickness, and that can be done with an open technology with this guide. So nevertheless, the soft tissue situation looks pleasing after the provisional, and then we go for the final restoration, which will be done CAD/CAM. And this is the happy patient at the end of the treatment. Another navigation technology is the dynamic navigation. The advantage of this technology is that we don't need a static guide made in advance. That means is less costs and less time necessary. The challenge is that the guided surgery needs to have a skill of the surgeon to follow a four-dimensional target in order to place the implant in the planned position. Also, in a full arch reconstructions, if we have residual teeth, we use the teeth as a reference to stabilize the reference. On the other, for the camera. On the other hand, we need, after the planning, on maybe a mini implant to as support for the camera reference. We can do all the procedures added to this technology, freehand, like sinus or also bone grafting technologies. And this case was done also then CAD/CAM at the end of the day. This is the OPG of the situation in the upper jaw and the aspect of the construction. Another advantage of the dynamic navigation is that the evaluation of the deviation is can be done immediately with a software immediately at the surgery. It seems to have, and this is of course what we want, to have a better precision as the freehand, less deviation as the freehand surgery, and of course the more experience gained, the more precise is the result. So all these advantages of the dynamic navigation and also of the static navigation is including a certain experience of the surgeon. There are differences in the accuracy of the result also regarding the surgeon's experience. And that is why by looking for technologies and accuracy tests, we through education we need to reduce the lack of accuracy of the result. So evaluating all these cases made by all these navigation techniques in full arch reconstructions over 3 years, we have a high success of the reconstructions. And just to mention some of preliminary parameters and realities after all these cases, we can resume that we have certain studies of accuracy, trueness, and precision. We need more studies on the accuracy, trueness, and precision of different devices. We need to make studies and tests by accuracy of matching, or to find technologies which are giving us a more accurate matching of the technologies and integration in the same workflow. Then the algorithm number 4 seems to be a valuable parameter or algorithm in the insertion depth and the buccal position of the implant in a static zone. or generally. Then the prosthetic solution is dictated by the tissue height and by the axis of the implant. We need to learn minimally invasive grafting techniques in order to keep the treatment minimally invasive, like soft tissue grafting with envelope and pinhole technique, like the SMART technique for the bone grafting, etc., if it's possible. We have to consider the S-shape emergence profile design using technologies which are predicting us and defining, are able to define us the form of the emergence profile, the displacement of the tissue and placement, tracing of the margin line of the abutment. So use the technology for that. The parameter of 3 to 4 millimeter inter-abutment distance is important in order to give the base for the papilla. So all those are already parameters known, which has to be respected and implemented as much as possible with or without help of artificial intelligence in the planning softwares. And of course, all these parameters, all these reconstructions has to be maintained with a certain recall menu, which is avoiding the peri-implantitis, mucositis, and peri-implantitis. Again, artificial intelligence and machine learning are fascinating technologies which are invading the existing softwares and existing technologies in digital dentistry. This, together with 3D printing and bioprinting, are new technologies which are coming in and making the digital workflow even more predictable, more minimally invasive, more aesthetic, and long-term success. And this is what we need to implement based on scientific results into the daily work in order to have with our patient a common satisfaction. With this, I would like to thank you for your attention and to wish you good luck on your digital implant dentistry field. Thank you so much.